Dr. Jim deMaine is our guest on this podcast, talking with us about advocacy in serious illness and his book, Facing Death, Finding Dignity, Hope, and Healing at the End. You're connected with the Heart of Hospice. I'm Jerry Finter, here with Helen Bauer.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
Everyone working in end-of-life care should be knowledgeable about medical aid and dying. We would recommend cultural anthropologist Anita Hanig's book, The Day I Die, The Untold Story of Assisted Dying in America. The book is unbiased, based on 5 years of immersive research. In telling the stories of ordinary Americans who decide to seek medical assistance in dying, Ms. Hanig uncovers the stigma against assisted dying and why someone might choose an assisted death. You can find The Day I Die, The Untold Story of Assisted Dying in America at anitahanig.com.
This is one of our people. Don't I say that every time we have a hospice professional on?
He is, absolutely. He understands the human condition. He understands the needs. He has seen it all.
He really has.
He has been a physician for a long, long time. So he's a retired pulmonary critical care MD. He is the emeritus clinical professor of medicine at the University of Washington School of Medicine, and he's written a book called Facing Death, Finding Dignity, Hope, and Healing at the End. And it was released back in September of 2020. He has seen so many of these situations where advanced care planning was used and where advanced care planning was not used.
Yes. Unnecessary and unwanted interventions. He understands. He's seen this in intensive care, in the pulmonary conditions, pulmonary patients, and he talks about these stories in his book. And basically, each story is, I wouldn't say a cautionary tale, but filled with wisdom and a little life lesson from each one about advanced care planning and the ethical considerations of different diagnoses like Alzheimer's and dementias and how that affects advanced care planning. So without further ado, because Jim can tell his story so much better than we can, here's our conversation with Dr. Jim deMaine.
Jim, it's such an honor to have you with us on the Heart of Hospice podcast. Thank you for joining us today.
Thank you. I'm happy to be here.
You have been a doctor for many years, a physician. So what did you experience in your years as a pulmonologist and critical care physician that made you interested in how we manage end-of-life care?
Well, when I would go in to do my rounds in the intensive care unit, there were a number of people on life support, on ventilators, or near death. And often families were struggling because they really didn't know what their loved one wanted. They had never had what I would call the conversation, that important conversation about what their wishes might be if they had a very serious life-threatening illness. So the families would say, well, gee, I don't know if mom wanted to keep going. She's so ill. I just don't know what she would tell us if she were here. And so when we would do family conferences, the families would have to use what I call substituted judgment as to whether to keep going or whether it was time to withdraw the ventilator and allow somebody to die peacefully. About 70% of hospital deaths are in the intensive care unit. So we're making those judgments all the time. And I got interested, well, let's try to back up. Let's see if there's a way that we can present information to people or get them talking at an earlier point in their lives. So the organization I worked for decided to reach out to everybody when they reached age 65 and invite them into a course. We called it Your Life, Your Choices. And it went through, okay, how do you judge your values, what's really important to you, and how do you apply that to what kind of treatments you might want if you had a very serious illness. And then what would a good death look like to you, That means different things to different people. I think that's really why I got interested. We set up this course. We talked to a lot of people. They were extremely appreciative. It wasn't just fill out these forms. It wasn't just fill out this advance directive or fill out this MOLST form or POLST form. It was have that conversation with your loved ones and find an advocate that really agrees with you and make sure that person is your durable power of attorney for healthcare so that they will act for you. So even during my practice career, we would have these sessions in various clinics. I got on the local radio station and started blogging about this, and then ultimately wrote my book. But I still speak to faith groups and Rotaries and other things. And of course, I'm not the only person that has written about this. But what I did was mainly share stories. And because I think just giving people forms to fill out or list a checklist doesn't really fill it out. So that's kind of what's been motivating me to try to get the word out. There are really good organizations that are doing the same thing. I mean, there's the Conversation Project, which was started by Ellen Goodman. She's a Pulitzer Prize-winning writer. Her mother had not a good death, and she felt very unprepared to make those kinds of decisions that would impact her mother's care. So she started the Conversation Project, and that can be found online, which is really an excellent source for people to go to because it has all kinds of videos and how to get started with a conversation. And I think it's very, very helpful. My favorite book to get people thinking is actually Atul Gawande's book called Being Mortal. And that, I think, gets a lot of people thinking about, well, we're not going to live forever. Death has to come into the conversation at some point in all our lives. We live in denial, which I think is okay. We have to enjoy the day and enjoy the lives. But on the other hand, the inevitable will happen. There's an old Onion cartoon, Onion humor magazine, that has a graph of world mortality, and it stays at 100%. So we're not going to get out of this alive. And death is I think, coming into the conversation more. I think people are talking about it more. I think with the COVID pandemic, very unfortunately, it's been thrust onto our doorsteps. And it's been a very, very difficult couple of years, but I don't really know how much it's actually helped to have the conversation, but I think it really has gotten people going.
Advanced care planning is such an important piece of this whole life, really, because as you say, we're not going to get out of here alive. We all will die. And it's not something we want to think about every day, obviously, but it does need to be something that we have to consider, and we have to share those conversations with our significant people in our lives. So we do have a lot of information about the Conversation Project. We've actually had the opportunity to interview Ellen Goodman. It's been a few years back, but we did have that opportunity to talk to her. And we also talk about what's called National Healthcare Decisions Day, right, which just happens to be today,
yes,
actually.
Today is National Healthcare. The day that we're recording is NHDD 2022.
Yeah, wonderful.
So good timing.
I sent them my book and hope that they've looked at it and read it. I didn't get feedback yet, but I'm sure they have.
Good.
It would be great. So, no, I was just thinking about what you were saying about the pandemic. It's been a hard couple of years. And I think that in a way, the pandemic has sort of blown away the cobwebs and revealed some of our flaws. I mean, we knew the system was flawed, right? Healthcare and end of life in this country are flawed. We don't handle it very well. But I think it's really showed us the inequities of those who engage in end of life care. right? The racial inequities. And it also showed us that we don't talk about advanced care planning, not just often enough, but with enough depth. We've got to talk about the ventilators and what means quality of life and how far would you go and how much would you want? What kind of interventions would you want? Where do you see opportunities for how we're talking about and how we do advanced care planning?
Well, I think, number one, physicians have to buy into it. There's some critical articles about advanced care planning saying it doesn't really work, but it's so hard to measure. I think if you just look at the forms, that's not the key piece of it. The key piece of it is the conversation and having people talking. So I think medical schools are getting better. We are training young physicians actually how to have conversations. There's an interesting app that you can download. It's called Vital Talk. And Vital Talk gives various dialogue and conversations as to how physicians, providers should talk to people with serious illness. And it has various layers. It's really quite good. Minority groups, as you mentioned, are a particular issue. As a Caucasian person, I cannot really truly understand the experience of a Black person or an Asian person or somebody from Muslim culture. We all look at the world through different lens. So I think we need to have special approaches, more culturally understanding approaches. I did give a talk to the Central Area Senior Center here in Seattle. There's a Mayor's Council for African American Elders here in Seattle. And I talked to them and they said, well, why don't you come and talk to one of our senior centers, predominantly African American. We started talking. Initially, they thought the talk would be just about choosing funeral homes and that kind of thing. But when I got into the talk, one lady raised her hand and said, Dr. deMaine, if I'm in real pain, will a white doctor believe me? And so we're kind of at that level of mistrust of the healthcare system. And it's well-deserved mistrust, actually, from some of the historical things that have happened. But I think if we have more physicians trained that are African American, if we have more cross-cultural training, then we can begin to more sensibly approach the people with cultural differences. I think going through their faith groups is a very good way if pastors come on board and then they begin talking to their groups. There was a PBS video about an African-American family with two children that both had severe sickle cell anemia. And one died a very painful death. And when the other one was dying, they were approached by the use of hospice. And they thought if they enrolled her son in hospice, that he would be taken off somewhere, that they wouldn't be involved in his care anymore. So complete misunderstanding of what hospice could offer. But through their pastor and through their African-American physician, they were able to have their son enrolled in hospice. And it was a true blessing, and they passed that on to their congregation. So I think that kind of, it's got to be almost word of mouth and through their own authority figures, that kind of thing will seep out into the community. And of course, I think political leaders can step in too. I mean, if we hear it from a governor or a president or head of an organization, these people carry a lot of moral weight. So
that's true.
It's nice we do have a National Healthcare Decisions Day. I think getting that word out, though, is still difficult.
Well, and let's face it, advanced care planning discussions are never a one conversation job.
Absolutely.
Right? You're never completed. So the fact that we have one day, that's awesome, except really every day should be National Healthcare Decisions Day.
Yeah.
Right? It should be ongoing conversations. Yeah, you talk about in your book, in your book, Facing Death, Finding Dignity, Hope, and Healing at the End. You talk about the video, and I wanted to highlight that. It's called Unequal Treatment, and it talks about the widespread lack of trust in hospice within the Black community. Is that a video that you can access online that our listeners could find?
I think so. I think it was a PBS video, actually on the PBS Evening News. I should have put a link in my book, but I suspect it can be found through their website.
Okay. So if I can find the link, I will definitely include that in our show notes so that our listeners can find it. I was very struck by that story because the lack of confidence that the African American community has. And then here you are, a Caucasian physician coming in to talk to this faith community. And I'm sure they looked at you thinking, he can't relate. And he's on the other side. He is a provider inside the healthcare community. So I can imagine there were more than a few of them that looked at you and thought, this guy's not going to really bring any value because he can't see it from our point of view. It's an interesting conversation, I'm sure.
Yeah, I think in the evaluation, there were a couple of people that felt that way. I don't think there's a uniform reaction within that community. Some are more trusting than others, but still, given the Tuskegee experiment and the discrimination in the military during the war, I have a friend actually who passed away a couple of years ago who was a Tuskegee flyer, and he was describing the discrimination experiences that he had, even as an officer during the war, until things began to open up.
That's sad.
Terrible things.
Yeah, that's very sad. Well, advanced care planning is something that's really, really important, and I'm glad that you're emphasizing this. So you said that you started, or your organization started, a program called Your Life, Your Choices. Is that right?
That's right. Yeah.
So tell us some of the stories that's come out of that. Was there one in particular that has stood out to you?
Well, I would just tell stories during the presentation. What I wanted to tell people right up front, that they had the right to have the type of healthcare at the end of their life that they wanted, that coincided with their values. But because they have that right, they do have responsibilities to let their healthcare team and their loved ones know really what mattered most to them and what kind of care they might want. So I would just tell stories. I'll tell the story that I start a lot of talks with, but also early on in my book. And being a pulmonologist, I had a lot of patients with emphysema, COPD, and it's a very tough way to live out your final years and your final breaths. And this fellow named Larry was a fairly crusty old guy, had pretty bad COPD. He had a lot of trouble quitting smoking, and he finally did, but it was too late. He really had fairly advanced emphysema, and he had a lot of recurrent infections, was in and out of the hospital, and each time he was a little bit more and more discouraged. And one day when he was in the office, he said, "Hey, Doc, I want to take you out to lunch." So he wanted to communicate very directly with me what he wanted. Actually, initially, I thought he was going to try to sell me something because he was a super salesman. But he wanted to really show me on the kind of treatment he wanted. We went out to a local restaurant, and he said, I want you to help me at the end. And I said, well, I'm not Dr. Kevorkian, but there are things that we can do to ease you at the end. And he said, well, what's that? And I said, well, with COPD and your terrible shortness of breath and gasping, the best drug is morphine. Just small doses. Well, he asked me, what could this do for me? And I said, well, take away your shortness of breath, give you a sense of euphoria, make you sleepy, and give you a sense of peace. And he said, well, gosh, that's exactly what I would want. And I said, well, there's a downside. It can speed up your death by a matter of hours or even days. And he said, that's not what I want. I just want that comfort at the end. I don't worry about another day or two. So I said, well, talk this over with your sons and get back to me. And he said they were on board. So it went a couple of months, but then he showed up at our emergency room, and I got a call at home, and they said he was there, and they wanted to put him in the intensive care unit. And I said, well, I'm not sure he would really want to go there. Let me come in and talk to him. So I saw him in the ER, and he looked me right in the eye, and he was kind of gasping and blue, but he was alert. And he said, remember what we talked about? And so I kind of reviewed the plan with him again, and we did not put him in the ICU. We put him on a medical unit, and there were very experienced, wonderful nurses there that were on board with the plan of just giving him titrated doses of morphine with a low baseline drip. And he gradually fell asleep and died peacefully that night. And then I got a wonderful letter from his sons thanking me and said, if Dad could come back, he'd shake your hand. And this is what we would call now palliative care, or even aggressive palliative care. And, people say, well, aren't you just killing the person by doing that? And the whole question is intent. And it's called the double effect. And ethics people debate this, but the intent is not to euthanize a patient or to kill somebody. The intent is to relieve their suffering in a fairly aggressive way sometimes. And that is now medically acceptable to all the specialty societies within the standard medical community. And a lot of people don't realize that their pain or their suffering can really be aggressively addressed. So I often start the talk, with things like that. I do show a video from Angelo Volandes at Harvard. He and his wife put together a video. She's a physician and a lawyer and African American. So I often show that video. It goes through, full care, what that means, and it shows somebody getting CPR and shows somebody on a ventilator. Then it shows selective care. It's kind of what you see on your pulse form. Full care. See selective care where you might want IVs, antibiotics, usual medical care, except no heroic CPR ventilator. And then it goes on to comfort care. And that if you just use comfort care, you kind of know you're on a trajectory toward death, but all you want is treatment of your symptoms. So I show that video. And then I show a funny video from Ellen Goodman's website, actually, on choosing an advocate and choosing a power of attorney, basically. And it shows various people you would not want to have as your power of attorney. Right. The ones that aren't there, that are off skiing in Peru or something, and ones that can't listen, or ones that have totally made up their mind. What you're looking for is the good listener, the caring person, the one that can sit by your bedside, hold your hand, but also one that can be a really strong advocate and stand up to maybe other members in the family or to the healthcare team sometimes. I was caring for another patient with COPD. He was a physician, OBGYN, very nice guy. Again, could not quit smoking. He got very sick and hospitalized at a time I was out of town. And he had very clearly said he did not want a ventilator. He wanted to go peacefully, and his wife was on board with that. But my colleague came in who was younger and, more, I guess, aggressive than I in terms of wanting to, do everything. And he was trying to talk them into a ventilator, and the conversation got, went off track a little bit. And he kind of said, well, I don't think you're making the right choice. I think you need to rethink this. And basically, my friend's wife threw him out of the room.
Good for her.
She was a good advocate. And he died peacefully during that hospitalization. That brings up another point that I remind people that, when we're hospitalized now, often we're cared for by people that have never met us or don't know us at all. We have hospitalists. We don't really see the primary care physicians in the hospital or included as part of the team, which I think is a real shortcoming in end-of-life care. Somehow or other, we need to close that loop and make sure that because the primary care physician will be that strong advocate, because they would know you, know your values. Hopefully they've had the conversation with you. Hopefully they filled out the pulse form with you if you're seriously ill. And I mean, that raises another issue, really. And if it gets into this whole advanced directive thing, if you have an advanced directive, can you be sure it'll be found?
Right.
You know?
Oh, yeah, that's very important. You don't want this advanced directive stuck in, a
safe
lock
deposit box.
Yeah, a safe deposit box that you can't get to in a really emergency moment.
Yeah, we don't have a good national way of figuring this out yet. I think it will come. I mean, people are doing, these little video clips. They're doing thumb drives you can carry with you. They're doing, Oregon has a registry. So any pulse that is filled out goes into a statewide registry that is accessible by 911. When you call them, they can immediately pull up your pulse form or your advanced directive. There are websites that offer this. My Directives and Prepare for Your Care both have these kind of websites. I think I referenced in my book. And some states will have a medallion that says "Do not resuscitate" or a wristband, but a lot of states don't have laws about those. So the medics are saying, well, gee, if I just see this wristband, are they wearing it for fun or is it for real? And, they're in a little bit of a dilemma. So they will, if there's a loved one nearby, the medics will often get confirmation from a loved one. Because if you call 911, you're likely to get resuscitated unless there's very clear evidence that you don't want.
And isn't that your intent? I mean, you call 911 out of panic. What is it that you're wanting from that service?
Well, it may be a stranger that's calling 911 or even a panicked spouse that doesn't know what to do.
Sure.
Even though you have a pulse. Certainly, if you can call them yourself, you generally want everything done. But maybe you're just having overwhelming pain and you want that addressed. I wonder if the 911 operators are keeping diaries. It would be fascinating to see a book written by one of them. And there probably is a book out there of stories and crazy calls that they get. But it's very difficult for the responders not to do everything because that's what they're trained to do. Right. And the same in emergency room or same in intensive care unit. Our healthcare system is set up to save lives. But at the end of a life, maybe we don't want to be saved. So each individual is going to be different in their own way.
Jim, you have worked as a physician for many years now. You've seen all these different scenarios, people who had advanced care plans, who had the advanced directives, people who didn't. How has working in medicine all these years affected your advanced care planning for yourself?
We assume that you have one.
I do. Yeah, my wife has heard me give this talk, I don't know how many times, Your Life, Your Choices, or I go to a Rotary or I go to another retirement community and talk, and then we have conversations. Well, I'm 83 years old now, and I have some health issues. I've pretty much, the way I filled out my pulse form, I said, well, if my heart stops, I do not think I'd want to be resuscitated, because going with your heart stopping is such a painless and easy way to go. It's not likely to happen. Most of us, as we age, will just age by, in a situation that goes like this. Sudden death from a heart attack or arrhythmia is getting much, much less common. So I would not want to have them give me shocks and do resuscitation because in my age group and my underlying illness, my chance of making a meaningful recovery is about 1 out of 10, maybe. Even for somebody that's baseline relatively healthy, the national survival rate from CPR is around 15%, unless you're immediately found, immediate CPR, immediate defibrillation, in otherwise good health, and in a major community with major trauma hospital, then your survival rate is quite a bit higher. So under the second part of the pulse where it says full treatment, I would want full treatment. I would want antibiotics for pneumonia. I would want, whatever could be done. I'd want my hip repaired or my appendix taken out or whatever needs to be done. So I've not put any limits on my care other than having CPR. If I did have pneumonia and let's say I got COVID and I had pneumonia, but I had a good chance of pulling through with the drugs we have now, I would want a ventilator for a short period of time, a week or two, but I wouldn't want a longer period. And that's the kind of thing you have to talk to your surrogate about and your others so that they kind of know your values and what your limits of what you would want are. And of course, at the end of my life, I would want hospice and comfort care. There's a saying that if you die without hospice, it's like having surgery without anesthesia. So.
That's interesting. So you're 83. You have your advance directive, all the advanced care planning done. I'm 62. Helen's a little bit younger than I am. Uh-huh. What age should a person begin thinking about advanced care planning? And this is a leading question. I think I know where we're going to go with it, but I'm throwing it out there for you to take a swing at it. What age should a person start thinking about advanced care planning?
Yeah, I think at any age we need to have some kind of plan in place and share our thoughts with our loved ones, our family. I gave this talk to University of Washington Law School students a couple of times over the last several years, and they were discussing the case of Nancy Cruzan. It was a young woman who unfortunately went off the road into a ravine in an isolated accident and wasn't found until quite a bit later. And she was in a persistent vegetative state, kept alive with a feeding tube, did not require a ventilator, but over months was never making any progress. The law students were debating, well, what happened was the family wanted to remove the feeding tube, but the hospital said this would be committing murder, or basically killing her, and we can't allow that. So they basically were at an impasse, and it went all the way to the Supreme Court, and they allowed that to occur. And so now, we don't even debate it that much, when it's happening. So I asked the law students, how many of you have an advance directive? Well, nobody did. In fact, none of them even had a will. So, at that age, things often just don't happen.
Right. And these were lawyers, or at least lawyers to be.
These were lawyers.
Yes.
And it has happened, where there's a woman whose husband suddenly passed away with a heart issue, I guess. And she had no information about him. She didn't know how to unlock his cell phone. She didn't know any of the account numbers. She didn't, of course, know anything. That's a part of advanced care planning, is making sure that the information you have is retrievable by somebody. And she's written a book called Get Your Stuff Together. And there's a website like that. But it sounds kind of humorous, but you really need to not only have somebody have access to your passwords, but also have access to your values and what's really important to you. And would you be willing to be on a long-term ventilator, even if there was only a 2% chance that you might even survive, even though you wouldn't survive in a normal capacity. Or if you had dementia, I mentioned the dementia directive in my book, and I had a woman after a talk, she came up to me and said, Dr. deMaine, my husband always told me that he wanted everything done. He wanted full life support. He wanted to be retrieved from whatever might be going on. And I said, now he's developed dementia, and I don't know what to do because I said, well, do you think it would benefit him to have CPR? She said, no, I really don't think so. But his wishes stated to me were this. So she really had an emotional dilemma. I tried to phase it in the reverse, saying, well, he's no longer the same person. He's really shifted into a different person. He's no longer the being that you really knew. And so I think you work with your pastor and your doctor or whoever is really close to you and try to look at it that way. And she was kind of stuck. She kind of walked away, shaking her head, saying, well, I really don't know what to do. So any kind of planning that we can do to tell our loved ones what we might want if we got into dementia, particularly in the far stages of dementia, would we want aggressive feeding? That's always an issue of somebody with very far advanced dementia, is how much, well, we know feeding tubes are not good in dementia. They actually die. People die quicker with feeding tubes. But what would you want? Would you want pretty much force feeding, or would you want to just die peacefully without so much attempt to keep you going if you had really advanced dementia and didn't recognize this anymore and were not the same person at all? So Brock Gassner had published, and you can just go online and just type in dementia directive. It is fairly non-complex, if you will. It gives kind of mild or moderate or severe dementia and what your wishes in general might be in those stages of dementia. Again, that's, I think, another part of advanced care planning that we should all consider, because once we hit age 90, about a third of us are going to have some degree of dementia, unless we have some pretty breakthrough drugs, which we don't have at this point.
Right. So a dementia directive is actually mentioned. You talk about it in your book, and that's such a good piece in there. And really something that's very important for us to consider is a dementia directive, because we know that Alzheimer's and dementia is a disease that is becoming more prevalent in our society. So we really need to make that a consideration when we're thinking about an advanced care plan.
Yeah. And those decisions are so nuanced. It's a very complex situation. And when it comes to advanced care planning for dementia-related, Alzheimer's, dementia-related diagnoses, you've got things, we always talk about advanced care planning with don't make promises that you can't keep. The biggest being, I promise I will never put you in a facility.
Yeah.
I will always keep you at home. But I think that goes back to what is a realistic picture of dying at home? Well, a good death may not be one where you're at home. It may be that you need to be in a facility related to safety or wandering or, aggression, agitation, whatever. There's so many different nuances to that. And I think in advanced care planning, what I see is we hit what I have started to call the big basics. We get the POLST form, we get a DNR that, we have an out-of-hospital DNR form here in Texas. It's just a one-page form. Mm-hmm. We do the big things. We'll choose a medical power of attorney or a proxy. And then there's no discussion after that. There's no discussion of quality of life and all the smaller pieces. Where do you want to die? Are you comfortable with your wife providing your personal care? There's so many different pieces to that. And, we talked about force feeding, and I'd like to touch on that because We use the term force feeding in hospice and palliative care. And I think there's maybe some misconception of what that actually means for an Alzheimer's or a dementia patient. And it's not that we are forcing food into a patient, but if the patient reflexively opens their mouth, when seated at a table, we put the food in.
Yeah.
Or the caregiver is putting the food in. And that is what we consider force feeding.
Yeah.
Yeah, it's not as if you're holding someone down and putting the, actually forcing the food into their mouths. But as a body actively begins to shut itself down in Alzheimer's and dementia, that inability to eat, those little pieces that fall away, that is natural disease progression. That is the body's way of preparing itself to shut itself off. And I think there's so many controversial and ethical decisions and discussions, when it comes to advanced care planning related to Alzheimer's and dementia.
Yeah, I had both of my sisters older than I passed away at home with hospice care, and it was not easy. They both had different issues. My one sister, first of all, had trouble getting an accurate diagnosis established. I had to be an advocate to send her to a couple of different major institutions before they finally diagnosed pulmonary fibrosis, which is basically very difficult to treat. And she was in rural Pennsylvania, so it was far away from the hospice. And so it was not easy to get established or have the frequency of visits. And, family members have to be trained and they have to become caregivers and they have to learn how to give the morphine or whatever is being used or put on the patches, and they have to do the body care and everything else. I mean, it's a real heavy load. And sometimes little things get missed. My sweet sister on hospice, her husband called me and said, my sister had this terrible nosebleed, cold pack, died, and she was basically still having some bleeding, and she did not want to go into the emergency room. And my sweet sister said to me, Jim, is it illegal to die from a nosebleed? And I said, I didn't want to answer it right there. I said, well, keep trying with that, but are you taking any kind of blood thinner? And she said, well, no, I just take my baby aspirin. And I said, why in the world is a dying person trying to prevent a heart attack by taking a baby aspirin? So people hadn't been critical enough in terms of minimizing her medications. Fortunately, the nosebleed did stop, and she was able to die at home. My other sister had a litany of medical problems, but finally had a paralytic stroke. So she had hemiparalysis, and they wanted to send her. And by the way, they did not find her advance directive on admission to the hospital, even though it was in her medical records. And they went ahead and put in a feeding tube into her stomach, what we call a PEG tube. So she was getting feedings, and they wanted to send her to rehab, and she said, no, I want to die at home. So basically, she felt her life was at an end, and she wanted to be in her old Pennsylvania farmhouse, but it put tremendous burden on her children, none of whom had medical background. And they also disagreed among themselves about the use of this feeding tube. One of them on his shift would sneak in some feeding, some milk or something like that. So there was disagreement there. Finally, they did hire in some aides. I think time in more of an inpatient hospice house or something like that, some more respite care for the family would have been some benefit for her, because dying from a stroke at home, where it's going to be a much more prolonged process of not eating and not drinking, was a difficult scenario for her. But on the other hand, I've had wonderful experiences with hospice. I had one lady of Asian descent who had a weird condition called primary pulmonary hypertension. the arteries in the lung develop high blood pressure, whereas it should be a low pressure system. And she was going into heart failure because of that and on oxygen. And she got to a point where she would have been a reasonable candidate for a lung transplant. And I wanted to send her to the University Hospital, but she said, no, I just don't want to go there. She said, I've had a good life, and I just feel I'm in the Lord's hands, and that just sounds too aggressive to me. And so she went off to Guam, actually, on oxygen, had a nice visit there, sent me a postcard, came back. And again, I said, well, have your husband come in. So her husband came in, and he agreed with her plan. He said, no, that's okay. You know, we're able to get by with all that. So she, at that point, transitioned to hospice care. And I would get nice electronic notes from hospice, but she was on kind of my peripheral vision at that point in terms of my medical practice. But I got a call from the hospice nurse saying that she would like me to stop by their home. So it was a nice home in a suburban area, not too far from the hospital. And I went up and knocked at the door, and I could hear music coming from within. And a grandchild answered the door and ran to get his grandpa. And there was my patient, I'll call her Bertha. She was in a hospital bed right in the middle of the living room. She had her oxygen going. The grandkids were running around all over the place. Food was all over the table, and music was going. And she was probably on the right dose of medication. She had just a sleepy smile on her face, and she recognized me, and I just sat with her for a while. But that was, to me, just kind of the idyllic home death where the family could be around. She had plenty of caregiving. Nobody was wearing out. And she died very, very peacefully at home. So the whole experience kind of, as you say, is very nuanced. It depends on the family structure, their culture, how well their wishes have been expressed, and then the very, very difficult decisions that you almost can't think of ahead of time that come up. There was one person here that said she wanted to die alone, and maybe she didn't want people to see her suffering or whatever. So she was over in our care unit, and many, many people wanted to go see her, but they tried to respect her wishes. So you never really know for sure.
Right. Jim, we could talk about this for so long, and I know you've got so many stories that you could tell us about this. This is really good. We would encourage our listeners to get a copy of your book. It's called Facing Death, Finding Dignity, Hope, and Healing at the End. And you share many, many stories in your book. And we really want to encourage our listeners to get a hold of your book. I assume it's on Amazon?
Yeah, it's on Amazon, and you can get it from Barnes & Noble, or I like to support the local bookstore. They can always order it from your local bookstore.
Yes, absolutely. Absolutely. Jim, thank you so much for spending this time with us today. We're glad to get connected with you and connect you with our listeners. And thank you for sharing your wisdom and your insights and your experience, not only with us today, but also in your book. And again, we want to encourage our listeners to take advantage of getting a hold of your book and reading the things that you've shared with us in the book.
Well, thank you, Helen and Jerry. It's been a privilege talking to you. And thanks so much for getting the word out, not necessarily about my book, but about the advanced care planning and the necessity to have those conversations.
I love the stories. I come back to that time and time again, but I love the stories. And Jim has just this pocket full
he does.
of stories to tell. And so many that are stories that end well and some stories that don't end so well.
He even says in the book, after some of the stories, that, they gave him pause. He needed to think. He needed to consider. And there were times he wasn't sure what the exact solution was, what the best solution or the most ethical solution was. He talked in the interview about double effect, which is an ethic principle. Basically, what it comes down to is you are weighing benefit versus burden and what that balance is. So yes, we give morphine to alleviate pain and alleviate shortness of breath, to calm the patient and to provide that sense of euphoria. And at the expense of what? So what is the burden of that? The burden of that is it may shorten the days that a patient has. But the benefit of easing shortness of breath, which is huge, far outweighs. There's so much more benefit than burden. And of course, we never want to confuse the fact that hospice never precipitates death intentionally.
Right. We never advance death, nor do we stop death.
Exactly. We don't seek to prolong it or precipitate it out. But there are ethical considerations with use of medications that we always consider. And he said, you're doing it with the best interest of the patient in mind. It's always about the benefit to the patient. That's
right.
Why those decisions are so nuanced, like we were talking about. You have to look at each situation. A blanket advance directive or POLST, a POLST, can't cover all those different scenarios.
No, and it really comes back to, what does this person want?
And did he or she discuss it with the people who are going to be not only their spokesperson, their decision maker, but also their advocates? Because even the healthcare system isn't friendly to some of these things.
Right. So Jim told us a story after we had stopped the recording about another fellow physician who had COPD. And it just happened that Jim was away on vacation or out of town when his friend became very seriously ill and went to the hospital. And another physician kept pushing and pushing for him to be put on a ventilator until finally his friend's wife just kicked the physician out of the room and said, "We're done with you."
Exactly. So being an advocate for yourself, or having an advocate that really knows who you are, it's more than the paperwork. It has to be more than the paperwork. You've got to develop it, figure out what your plan is, what your wishes are. Then you've got to document it, put it down on those forms that are legal in your area, that are clear, and hit the big points, and then discuss it. Because it's not a one-off conversation.
No, it has to take several conversations sometimes with different people so that it all begins to gel. Everybody's on the same page that way. So here's what we're going to tell you over and over again. Have those conversations. Just because you put it down on paper is not enough. Have those conversations with people. So we would encourage you to get Dr. Jim deMaine's book. It's a really incredible book. It has so much good information in it. And take the time. You can check it out on Amazon, or you can also go to your independent bookseller and ask them to order it. They would be happy to do it if you would like to find it from your independent bookseller.
It's reasonably priced. It's under $20, and it's called Facing Death, Finding Dignity, Hope, and Healing at the End.
Thanks for listening to The Heart of Hospice. I'm Jerry Fenter here with Helen Bauer. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening and leave a rating or a review on Apple Podcasts.
To connect with us, just send an email to host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.